So picture this. You're reading a newly published, absolutely groundbreaking medical study. I mean, the headlines are already calling it a miracle drug. The data is literally flawless. The p-values are incredibly small. But then a few months go by, and that exact same drug completely fails to help the actual living, breathing patient sitting right in front of you in a standard outpatient clinic. It makes you wonder, right? Why does a perfect treatment in the lab just completely fall apart out in the real world?
Well, welcome to today's Explainer, where we're going to decode the fundamental tug-of-war at the very heart of medical research. We're looking at the primary compromise you have to make when evaluating a clinical trial design, basically managing the architectural tension between a study's structural purity on one hand and its actual, practical, real-world usefulness on the other. It's this incredibly delicate balance between internal and external validity.
Okay, let's dive into this. We've got a quick roadmap for you today. First, the gold standard paradox. Then, internal validity and efficacy. External validity and effectiveness. The architectural trade-off. And finally, applying evidence to patients.
Let's jump right into Section 1, the gold standard paradox.
You know, in medical research, Phase 3 randomized controlled trials, or RCTs, are universally considered the absolute gold standard for clinical evidence. When we want to prove an intervention works, we randomly assign patients to a treatment group or a control group just to balance out any confounders. But as we start to dig into this, we kind of have to peel back the layers to reveal a core vulnerability in how these trials are designed, and that's the fact that perfect, pristine laboratory conditions simply do not match wonderfully flawed, everyday human patients.
Right, which brings us to Section 2, internal validity and efficacy. Let's look at the first end of our tug-of-war rope.
Notice the focus on the word pure when we talk about this. Internal validity answers a fundamental question. Did the experimental intervention genuinely cause the change we're seeing in our outcome, or was it just, random error, selection bias, or some confounding factor? High internal validity means the structural integrity of the study itself is totally rock solid. It means we have successfully excluded all those alternative explanations, and we know for sure the drug actually caused the effect.
To achieve this level of purity, trialists essentially have to build scientific armor around their study. They use extremely strict randomization. They use double blinding, so neither the patient nor the doctor has any idea who's getting the actual drug. And they actively eliminate patients who have multiple comorbidities, complex medication regimens, or even advanced age. Now, this successfully isolates a pure biological mechanism, which is great, but let's be honest, it creates a highly artificial laboratory environment that completely separates the study from the messy realities of routine clinical practice.
And this visually brilliant setup illustrates those forces of bias and confounding. It's all that messy noise that threatens to ruin a perfectly good study. Those rigorous controls act as a literal brick wall against the noise. When you successfully block out the confounding variables, your internal validity absolutely skyrockets.
Which brings us to a really critical term, efficacy. Efficacy measures exactly how well an intervention performs under these ideal, highly controlled circumstances. It's essentially a direct reflection of internal validity. It is exactly what we're testing for when we put our trial in a perfectly sterile, controlled bubble and just watch that pure biological mechanism go to work.
Moving on to Section 3, external validity and effectiveness. Let's flip the coin.
So we're leaving the pristine lab and entering the real world. This brings us to external validity, which is also known as generalizability. This asks a pretty harsh question. Does the study population actually reflect the demographic, genetic, and clinical variations that we see in everyday medical practice? Like, can we safely apply these pristine conclusions to diverse patients who live totally outside the strict confines of that trial?
And just as efficacy mirrors internal validity, effectiveness mirrors external validity. Effectiveness evaluates how well that exact same intervention performs, not in a sterile bubble, but in routine, messy, everyday clinical practice. It's the gritty, real-world counterpart to efficacy.
Think about pragmatic clinical trials that truly embrace this reality. They recruit from diverse community clinics. They include individuals with multiple chronic health conditions, and they even allow for flexible, real-world dosing strategies. Because of this, they demonstrate exceptionally high external validity. But as you can probably guess, the messy real world introduces a ton of noise. Real patients miss their doses. They decide to eat a whole grapefruit for breakfast when they really shouldn't be mixing it with their meds, or they experience unmeasured environmental stress. All this real-world noise can obscure subtle treatment effects and in turn significantly lower the study's internal validity.
So, Section 4, the architectural trade-off.
This is the central tension right here, the execution gap that clinicians constantly have to navigate.
You can really think of trial design as a literal slider on an audio mixing board. If you dial up strict scientific control to maximize your internal validity and efficacy, you inherently dial down your generalizability and real-world effectiveness. It's a trade-off. You simply cannot have both perfectly maximized at the exact same time.
Let's actually ground this jargon in a real medical board scenario. Imagine an investigator testing a new medication for chronic obstructive pulmonary disease, or COPD, in the ER. Now, to standardize care perfectly, they decide to only enroll patients when a specific study nurse is present, say from 7 a.m. to 7 p.m. Okay, this creates fantastic internal controls, but what's the glaring limitation here? Generalizability. Because real patients in the broader population also have COPD exacerbations and go to the ER in the middle of the night. By restricting the hours, they've introduced a sampling bias that terribly limits the external validity.
Or consider the classic asthma inhaler paradox. A trial comes out reporting a massive reduction in exacerbations. Why? Well, because highly specialized research nurses were calling the patients every single day to explicitly verify their inhaler technique. Amazing internal validity, right? But then, when that same drug is prescribed in a standard clinic, it fails completely. Why? Because real-world patients inevitably skip doses or they just use the inhaler incorrectly. You get zero clinical effectiveness entirely due to poor external validity.
Let's wrap things up with Section 5, Applying Evidence to Patients.
How does a practicing clinician actually use all this knowledge? Well, doctors can't just skim the conclusion of a paper and immediately start prescribing. They have to perform a constant audit using 2 steps: appraise and apply. First, they appraise the internal validity. Like, is there a risk of bias or random error? Did the study actually measure what it claims to measure? And then they apply it. They take that evidence and individualize it, translating the rigid data to their specific patient's unique characteristics and real-world setting.
As a learner analyzing the literature, you've got to constantly ask yourself, are there compelling reasons why this highly controlled study doesn't apply to the wonderfully complex person sitting right in front of me? A trial's internal scientific purity should never be so artificial that it renders its findings completely useless for your actual patient population.
And this really brings us to the ultimate, true goal of evidence-based medicine: integrating the best available evidence with individual patient characteristics. It's just a constant, ongoing balancing act between the pristine purity of the laboratory and the wonderfully messy reality of individual human lives.
So I'll leave you with this provocative thought to carry into the rest of your studies. The very next time you see a medical headline claiming a new gold standard breakthrough, I want you to look closely at their inclusion criteria. If that trial actively excluded patients exactly like yours just to maintain its pristine internal validity, is its evidence actually useful to you? Keep that critical lens sharp, and thanks for joining me on this explainer.